So the past few decades that I've been doing this stuff, fasting has been gone through a transition in terms of public exposure. Except more recently, there's been a lot of materials published, particularly by people like Walter Longo and Luigi Fontana, particularly talking about intermittent fasting, modified fasting. The idea that you can narrow the feeding window. If you don't eat before a certain time in the morning and you don't eat after a certain time at night, you could have 12, 14, or 16 hours of fasting every single day. So if you have breakfast at 9, you don't have any food after, say, 6 p.m., there's this period of fasting time at night where you're not eating. And even that period of time is enough to induce metabolic changes that are thought to be helpful in terms of health promotion, disease prevention. You can augment that further with limited feeding windows. Maybe one day a week, on a day you can take it easy, you just eat fruits and vegetables. So your total caloric intake might be around 600 calories. If you have a couple pounds of fruit, a couple pounds of salad material, 600 to 800 calories. As a consequence, that reduced caloric intake results in progressive weight loss, and that progressive weight loss is thought to be associated with improved health. And these have become, this has been well published. There's lots of data out there now talking about the potential benefits of this. Of course, that's not what I'm going to be talking about today. What we're talking about today is water-only fasting. So prolonged water-only fasting, anywhere from 5 to 40 days, where you're in a controlled setting and you have nothing but water only. Water fasting is not the same as starving. Even though in the literature, it's often those terms are used synonymously, they're different. Fasting is when you have metabolic reserves that you can mobilize and use. If you fast long enough, you eventually deplete your available reserves, and then you enter a process called starvation. If you continue starvation, then you die. So we don't do that. It would be really bad on our outcome data. So the important thing with fasting is not everybody is a good candidate for prolonged water-only fasting. Most people can do intermittent fasting. Many people can do modified fasting, reduce caloric intake, they can do juice fasting, lots of things that they can do safely. But water-only fasting is not for everybody. The important thing is that there's a history, an exam, and laboratory evaluation done. And the reason we have to do that before we recommend long-term water-only fasting is, one, you want to make sure you identify the people where fasting can be harmful. And number two, you want to make sure you have enough information so that when you're in the process of fasting, you can tell the difference between a good thing that's happening and a bad thing. Sometimes they look very similar. And it's important on both levels. If you think something bad is happening and it's good, but you break your fast, you don't get the full benefit. If you think something is good and you keep going, then you could die, and that would be bad or have a bad outcome. Now, we know this can be done safely, and we know it can be done effectively because for the past 34 years, we've had 16,000 people undergo prolonged water-only fasting at the True North Health Center, and so far, everybody that's walked in to do fasting has been able to walk out. And as you'll hear in a moment, we've actually done a formal safety study looking at exactly how safe is this process. So one of the important things we do in deciding who's a good person, besides listening to their history and doing an exam, is we get certain types of laboratory testing done as a baseline. And this would be relevant whether you're doing a short-term fast or a very long-term fast. And those baseline data include things like blood tests that would look at liver and kidney function. Because it turns out you need to have certain minimal levels of liver and kidney function in order to be able to go in and adapt to the fasting process itself. And we also look at other things like your blood sugar levels and your blood counts, because you want to identify if there's problems with deficiency or anemia or other things that might interfere with the ability to fast. There are some people we know by history are not good candidates for fasting. If you're pregnant or you're lactating, fasting would be used extremely cautiously, because if you're lactating, you're going to lose your milk production. And that's, of course, a real serious problem for your baby. Anorexia nervosa is a condition different than, say, bulimia or other types of eating disorders that you may be able to use fasting. Anorexia nervosa is a condition that doesn't respond well to fasting, although those patients would like to fast. It's not a health promoting condition. Diabetes type 1. You need insulin in order to be able to adapt to fast. So if you don't make enough insulin, if your C-peptides and blood tests suggest you don't make enough insulin, water-only fasting could be a very serious or life-threatening problem. And actually, I have to say, of all the people that we've seen who have had complications, trying to fast type 1 diabetics is by far the most problematic condition. Type 2 diabetics actually make plenty of insulin. In fact, type 2 diabetics have more insulin than you do. But it doesn't work because there's insulin resistance, because the diet that makes them fat gives them insulin resistance. And so type 2 diabetes responds well, oftentimes, to fasting. But type 1 diabetic, where you're actually not making insulin, not so good. If you've had a recent stroke, myocardial infarction, pulmonary embolism, or DVT, water fasting can be problematic. Water fasting is not absolute protection against throwing clots. And so most of these patients are going to be on anticoagulant medications. If you withdraw those medications too quickly, you can induce serious problems. We don't fast patients on water only that have had those conditions. If you have severe kidney disease, you're not a good candidate for water-only fasting because you need your kidney function in order to fast effectively. Most of the toxins in your body are not going to be eliminated in your bowels. They're going to be eliminated in your urine, because the urine is the blood having been processed by the kidneys. But if your kidney function is inadequate in order to be able to keep up with this increasing load of detoxification that's going to occur with fasting, you can shut the kidneys down. Again, that would be very bad for the outcome data as well. Cardiac instability, atrial fibrillation, porphyria is a genetic condition where you don't process blood products properly. Deficiency, depletion, or cachexia in general. If you're in a depletion mode, obviously going on a water fast where you have no nutrient intake may not be a good idea. Medium-chain acetylcoenzyme A dehydrogenase deficiency, that's a genetic defect where you don't break down fatty acids. It happens in 1 in 10,000 people, but would certainly not result in a good outcome if you try to do prolonged fasting. Basically, in general, if you are unable to be stabilized off of most medications, the exceptions being things like hormone replacement therapy, like thyroid replacement therapy or something, but most medications, if you can't, in a controlled setting, be stabilized off most medications, probably modified fasting rather than water-only fasting is going to be recommended. And interestingly enough, the most important variable to long-term success, that is not long-term success getting through the fast, but long-term success at complying with diet and lifestyle changes, is conscientiousness. So people that are highly conscientious tend to have a much easier time adopting a health-promoting diet and lifestyle. People that are not conscientious typically have a lot of difficulty. And so lack of conscientiousness might also be an indication to be cautious about fasting, because you're not going to likely see good follow-up dietary change. Fasting duration ranges from a few days to several weeks, 5 to 40 days. At our clinic, we don't fast over 40 days because Dr. Burton, the gentleman I studied with, said he recommended not going beyond 40 days, even though he had done that extensively in his career. He said he finally discontinued fasting over 40 days because of sleep deprivation. And I said, oh, did the patients stop having the ability to sleep well? He said, no, they slept fine. He said, it was me. Turns out if you keep fast relatively short, up to about 40 days, you have relatively few complications. If you start doing very long fasting, the 60, 80, 90, 100 days, much more difficult problems can arise. Average fast at the Tumor Health Center is 1 to 3 weeks. It depends on the patient. One of the things you don't know is exactly what the ideal amount of time is until you see how the person responds to fasting. It's diagnostic as well as therapeutic. Some people actually don't respond to just one fast. Some people will take several fasts to undo the mess that's been created by, chronic diet, lifestyle misadventures. And again, you don't always know exactly how long that's going to be. One of the things we do is remain real flexible. People can book for short or long periods of time, but there's no penalty if they get done quicker. So they tend to book a little longer than we expect, and that way we have some flexibility. One of the problems for us is we're booked 3 or 4 months ahead. And so it's easy to shorten the stay, but it's not easy to extend the stay because we've already got commitments. Oh. Well, that's interesting. talk about this? You can't read that, that's okay. We had a patient recently, this will be a case report I guess we're going to be discussing now. This was a young woman, she was 42 years old. She had been diagnosed with follicular lymphoma, which is lymph cancer, and had progressed over a couple of years, and she'd seen her doctor, who had eventually referred her to the oncologist. And these tumors were large enough you could feel them externally, upper and lower part of her body. And her doctor, when she asked him if anything she could do to reverse the condition, he asked about diet. He said no, diet wasn't related to lymphoma, that she could eat whatever she wanted, unrestricted diet. When he was starting to refer her to the oncologist, she asked if she could do alternative treatment, like fasting. And he said no, fasting wouldn't help. Fasting was criminal quackery. And then she saw the oncologist at our local medical school, who also agreed. Normally they don't start chemotherapy right away with this condition because it doesn't work very well, it has a lot of side effects. And so they tend to wait until kind of there's no other choice. And he told her that he thought she was ready to begin some chemotherapy, acknowledged the limitations to treatment. I assured her that she didn't have to be on any type of restricted diet, that diet didn't matter with this condition, and that fasting would not be effective. So given that tremendous medical support, she decided to come to the True North Health Center and undergo medically supervised water-only fasting. She ended up fasting for 21 days. During that fast, you could actually feel these tumors disappearing. By the end of 3 weeks, we couldn't feel any evidence of tumors. She refed for 10 days. So during the fast, she lost 22 pounds in 3 weeks, which is about right. You lose about a pound a day. And in fact, let me just see if this will, there we go. So you can see she started off at 81 kilograms, and by the time we started fasting her, she was 78 kilograms. What do you think she did in the time between when we first examined her and she came in for fasting? Yeah, she adopted a whole plant food, SOS-free diet, during which time, interestingly enough, she lost some weight. During the fast, she went from 78 to 68 kilograms, and then on 6-month follow-up, she was at 63 kilograms. What was she doing in the 6 months after her initial fasting? She continued to eat a whole plant food, SOS-free diet. So when we were done, we sent her back to the medical school, and we asked her to see the same oncologist, and we gave her a little bit of coaching. And she saw the oncologist, who she said examined her, looked at her chart, looked at the picture on her chart. And he went back and examined her again, and he asked her what happened. And she said, well, I went to the criminal quacks and I did the fasting and the tumors went away. And he said, well, that's interesting. I'll have to give them a call. And then she said, I'd like to have a follow-up CT scan. He said, no. And he said, why do you want to have a CT scan? You're better. And she said, because I want to objectify the changes. And then he got a little nervous. He said, well, you don't need to. Clinically, you're better now. I've been doing this 25 years. And then she said, well, are you sure there's not cancer just below the... And he said, fine. Ordered the CT scan. Told her that she was still neutropenic. It's still a little gentle chemotherapy. But she refused. And at 6 months, her white count had normalized. By the time we got to a year, we decided to try to publish this paper in one of the medical journals. So I called up my colleague John McDougall. How many of you know John McDougall? Amiable, friendly guy. I said, you know, John, I've got this interesting case of lymphoma that's resolved with fasting and a plant-based SOS-free diet. I was thinking about submitting it to one of the journals. And he said, yeah, that's a good idea. I said, I thought I'd send it to the British Medical Journal. And he said, no, that's not a good idea. He said, don't do that. They're never going to publish it. It's a big impact journal. He said, he's submitted stuff. They always turn it down. They're just a bunch of jerks. Forget about it. So given that sage advice, I, of course, immediately sent it to the British Medical Journal. And we did have some back and forth and ups and downs with them, but eventually they did decide to publish this case report. So that was really good. The best part, I was able to call up McDougall and say, hey, John. Remember that case? I said, they published it in the British Medical Journal. Yeah. He says, I don't understand. I I said, yeah. He says, I think they like chiropractors. So we continue to track this patient, and you can see here, by 30 months, she had started to regain a little bit of weight, slipping and sliding off her diet a little bit, so she decided to come back in. And what we did at this point was we did a follow-up CT scan, and then we proceeded to do another fast. And at the end of that fast, of course, she was down lower than she was even at the end. And at 3 years post-treatment, she did really well. This was a CT scan of her. You can see the arrows pointing to her tumor and lack thereof. This was after the first fast, and this was just before the second fast. So this is before we even did the second fast. She's completely cancer-free at 3 years post-treatment. So no evidence of her lymphoma, and she's continued to comply and is doing very well. Now, interestingly enough, they invited us to submit a follow-up to see whether or not she would sustain her results, and we resubmitted the follow-up, and that's in review right now, so hopefully that will be published shortly. So anyway, 3 years, she's 136 pounds, CT says no cancer, she's feeling great, and she's done nothing except water-only fasting followed by a whole plant food SOS-free diet. Blood pressure. Most people develop high blood pressure by the time they retire. So most of the people you know that are 65 or older have elevated blood pressure, and it's a major associated risk factor for death and disability. The top number when you get your blood pressure measured, it's called the systolic blood pressure. It represents the pressure of the blood in the vessels when the heart contracts. And the bottom number, or diastolic blood pressure, represents the pressure in the vessels when the heart's in its relaxation mode. And both of those numbers are highly sensitive indicators of all-cause mortality, in other words, whether you're going to die prematurely. And the reason is blood pressure represents so many different things. In other words, when your blood pressure is up, you don't know which thing is screwed up, but something's screwed up. It could be you've plugged up your blood vessels with fat. It could be you have too big a blood volume from eating too much salt and other problems. It could be you've got too much stress, or the sympathetic nervous system is crunked down in the vessels, narrowing the size of the chamber. Could have kidney disease. You don't know exactly which of those or all of those things are contributing to the elevated blood pressure. But what you do know is when you make diet and lifestyle changes and that blood pressure comes down, whatever the rate limiting factor is, has been resolved. High blood pressure is big business. It's big money. It's the leading contributing cause of death and disability. It's the main justification for prescription medications. It's a great condition for the medical profession, because if you have high blood pressure, you go on medications 1, 2, 3, 5. How long? Forever. That's right. They guarantee you'll be sick forever. Your doctor will tell you you'll be on these drugs the rest of your life, we promise you. On the other hand, and of course, 800,000 people get strokes. The main reason people have strokes is high blood pressure. Interestingly enough, most of the people that will have heart attacks and strokes because of their blood pressure don't actually have blood pressure high enough to justify medication. Why don't we just give everybody blood pressure meds since it's so common? What if we put it in the public water supply? It's because if you take blood pressure medications before your blood pressure rises to a certain level, your risk of dying from the medications is higher than your risk of dying from the blood pressure. You have to have your blood pressure go up to a certain point where the risk factor for dying from the blood pressure is so high that you can justify the risk of dying from the blood pressure medication. And most people don't have blood pressure quite high enough to justify the risk of medication, even though that's 68% of the people that have heart attacks and strokes as a consequence of hypertension. You can't really legitimately give them medication. For example, if your blood pressure is 138/88 and you don't have end-organ target disease, you're more likely to die from taking the drugs than from the blood pressure. But you still have 5 times the risk of having a heart attack compared to somebody that has healthier blood pressure, say at 110/70. What's interesting, for every point systolic blood pressure drops 1 point, there's a 1% reduction in all-cause mortality. Death from any cause. And that goes all the way down probably to around 90/60, which is what normal blood pressure is actually considered.
Happens under 90/60.
Well, it turns out that most people, remember, it's a bell curve, so some people are going to be 88/54, and some people are going to be 110/70 at their optimal level. But overall, most people, when they go on these programs, that's where the target level ends up being. So, between 90 and 100/60. Now, the difference between 90 and 92 or 96 is very different than the difference between 140 and 142 and 146. So your risk becomes progressively less as you get into this rarefied area. The important thing to know, though, is 120/80 isn't necessarily optimal blood pressure. Because something's average doesn't make it healthy. And you don't want to be average, because average people who are developing high blood pressure have obesity and are dying prematurely. You want to be healthy. This is how we treat blood pressure. Diuretics and beta blockers and all kinds of different medications. What we know that works is interesting. Weight loss works. For every kilogram you lose, there's a 1.6 point drop in average in systolic blood pressure. Vegetarian high fiber diets work. Not drinking works. Even 2 drinks a week are enough to increase measurably people's blood pressure, and other conditions like breast cancer and other problems. Exercise works. It works pretty well. In fact, it works almost as well as any combination of medications, which will drop blood pressure an average of 12 points, but they have side effects. The blood pressure medications are famous for their side effects: chronic cough, fatigue, impotence, and death. John McDougall did a study where he combined these variables and he got an average drop of 17 points. Didn't get it published in the British Medical Journal. And then T. Colin Campbell from Cornell University, one of my heroes, came to the center. He had his own issues. He was the first scientist to isolate dioxin, and he developed some problems with dystonia. Came to the center, we did some fasting. Long story short, he was able to recover and got involved in our research. He took our research back to Cornell. He asked his assistant, Banu Parpia, to run our analysis. She said that when she first heard about this, she thought poor Dr. Campbell had suffered brain damage from fasting too long. Because the idea of some chiropractic quack starving people to treat their blood pressure was the stupidest idea she'd ever heard of. But when they ran the analysis, they found out that these were amongst the largest effect sizes that they'd ever seen. They took 174 consecutive patients with high blood pressure, all of which were able to lower their pressure enough to eliminate the need for medication. And in the case of stage 3 hypertension, where it starts at 180 points or more, we had an average effect size of 60 points. Now that, remember, their baseline was taken on medication. The end result was taken with no medications, and the average effect, despite the fact that they were artificially low starting on medications, was 60 points. That's the largest effect that anybody's ever shown in treating high blood pressure in humans, and we did it with water-only fasting followed by a whole plant food, SOS-free diet. That was eventually published in JMPT, and later we published a second paper that looked at borderline hypertensive, that is, people that had blood pressure elevated enough to increase the risk of death, but not enough to justify medications. And those patients, as you would expect, responded equally well. When it comes to treating high blood pressure in humans, there's nothing that works better than fasting. And when you do fasting and normalize blood pressure, if you're willing to do dangerous and radical things, like eat a health-promoting vegan SOS-free diet, get moderate exercise and sleep, you can sustain those results often, definitely. Now, after we published these papers, we were approached by the International Union of Operating Engineers, which is California's most powerful labor union. And we were asked, Dr. Lyle and I were asked to go to a meeting and present our data. These guys are the crane operators in California, the build your highways, they're big union, very powerful. We did a little presentation at the union, and they had all kinds of people there. They had a reviewer from the National Institute of Health there, they had representatives of the union who hired the union guys, they had an actuary that calculates, all the money and dollar business. It turns out union members get a pension benefit if they live to retirement, for every month they retire. So we presented this data, and immediately the contractors that hired these union guys were like, wait a second, we're already paying all this money for their health care, now we have to send them on some resort vacation. So then I described a little bit in detail what happens when you fast. Low back pain, headache, irritability, nausea, vomiting. After a while, they finally agreed maybe it wasn't a resort vacation, but they still objected. The NIH reviewer stood up and said he had analyzed our data, and he believed that if they implemented the program, it would save money, because they spent so much money on diabetes and hypertension, and cutting people's feet off and treating their strokes, that he thought it would result in a net savings. The actuary was the funny guy. He's been running numbers the whole time, little guy. And he says, excuse me, Dr. Goldhammer, if we do this program and it works, won't it dramatically increase our cost for retirement payouts by making them live longer? I know. Oh my God, they really think that way. I don't know what to say. The guy stands up, this guy, big guy. I know immediately he's got to be a crane operator because his neck's like twice the size of my thigh. He says, listen, little man, you need to remember who you work for. He said, you work for us. He says, why don't you calculate how much money we're going to save when I come back there and break your neck? And then they voted unanimously to make our program a fully covered benefit for any member of the union or their family that had diabetes or hypertension, and asked us to do a study to see whether it would save them money. And we took the first 30 consecutive members that they sent us with diabetes and hypertension. We did a study, we put them through an average 3-week stay. They lost an average of 26 pounds. We did a follow-up. Their average weight was down 28 pounds, which means they had maintained their weight loss a little bit more, not as much as I would have liked, but they maintained much of their blood pressure loss. But the important thing was the union saved more money in the first year on the direct reduced cost of care than the entire cost of the program. So they extended that. We did that for over a decade. And we treated 103 of these union guys using fasting and diet and continued to track their data. Another interesting case report was, this was a dentist. These case reports have all been published in peer-reviewed journals. If you go onto our website at truenorthhealth.com, they're all there. You can download the whole thing and read it. But this was a 44-year-old dentist at the time, and she'd suffered traumatic brain injury. She was outside, got hit in the head, and had, they think, a dural tear of some kind. Didn't heal up. Long story short, she goes on for 16 years of constant daily head pain. Can't work. Feels miserable. Calls up. Decides she wants to try fasting. So we bring her in with the understanding we would try to do a fast up to 40 days. During this fast, she had no relief the first 19 days, then wakes up, has 5 minutes of really weird sensation. And she said she took her a while to realize that it was the first time in 16 years she'd been out of pain. It lasted about 5 minutes and the pain came back. We went through 40 days of fasting, at which time, we were getting prepared to break the fast, but she insisted on going one more day. Because she says the men fast for 40 days. Moses, David, Elijah, and Jesus. And women always have to do a little bit more. So we let her go to 41 days. And by the end of the fast, she was out of acute pain, but she was still having some prodromal sensations. So we refed her for 6 months, rebuilt her, and then we put her on another fast for 40 days. And by the end of the second 40-day fast, she was out of pain. We've recently done a 6-year follow-up on her. She has no pain for 6 years. Wow. So she's doing really well. So then the real question is, well, okay, 40 days. I tell my patients they're in good company, But as far as, is it safe? So in order to answer that question, there are specific studies that are called fasting safety studies. And when Dr. Esser, who you all heard speak, was at our facility as an intern when he was a medical student, he really gave me a hard time that we hadn't done a fasting safety study. He insisted that we needed to do that in order to be able to make it possible for us and other people to get approval for human subcommittee to do long-term prospective studies. And so we agreed. Back then, of course, we didn't have a lot of the sophisticated automated computer systems in place, and so all of this had to be done manually. What that meant is every symptom on every patient for every day had to be charted, correlated. It was a very time-consuming process, but we did do it, and we eventually managed to write this paper that has now been published in one of the peer-reviewed journals. And basically, we used the common terminology criteria for adverse events from the National Cancer Institute, followed all kinds of standard protocols, and looked at all the adverse events that happen in fasting to determine, is it safe? And adverse events are divided into 5 categories. You can see them here. Category 5 is death. We didn't have any of those, fortunately. Number 4, life-threatening consequences. We had one of those. In this case, it was a person that developed very low blood sodium levels. And the treatment for it is you do intravenous feed, you bring it back up, they were fine. Category 3 events are serious events that you have to pay attention to. And category 1 and 2 are very mild events, nausea, low back pain, headache, all the things that we expect to see in fasting. We treated a wide variety of conditions because at the True North Health Center we do see a wide variety of problems. And we had a large number of people that went through this process. We don't need any of this. Bottom line, one of the most common adverse events were hypertension events. And you might say, well, if fasting is so effective in treating high blood pressure, why would you have 95 of your 300 adverse events being associated with hypertension? Here's how it works. If you come in and your blood pressure is 240, and the next day it's 220, and the next day it's 200, and the next day it's 190, and the next day it's 180, each one of those is an adverse event. Any day you register a pressure above 160, according to this criteria, it has to be registered as an adverse event. And so it turns out, of course, 95% of adverse events are mild to moderate, and hypertension is not a treatment-emergent adverse event. It's just a normal consequence of people with very high blood pressure normalizing. But just the way these studies are calculated, you follow a certain protocol. But that's why you have to be real careful sometimes when you read newspaper interpretations of these studies, because they can say, oh, well, fasting is a risk factor for high blood pressure. Of course, it's not at all, but if you don't read it carefully. Statistics don't lie, but liars use statistics, they say. So bottom line is, it turns out that majority of adverse events are mild, the majority of adverse events are known to occur during fasting. There is a correlation, but it's slight, between adverse events and length of fasting, but not severity. So the idea that you're going to have a more severe event because you're fasting longer or you're older, for example, turns out not to be true. And that's important because up till this study, they said you couldn't fast people over 65 because they were too old. So now we have data that suggests, no, whether you're 65 or 70 or 75, you're not at any more risk because of age per se. And that's going to allow, again, us and all other researchers that are interested in pursuing research in long-term fasting to be able to do this. So we're very pleased that this finally did get published. Now, I have to take a look here because I don't think we have very much time. Are you in here, Mark?
Yeah.
What time do I have? What time do we need to complete so that we'll be back on schedule?
Why don't you complete in 10 minutes?
Okay. So, here's what we're going to do. Mechanisms of fasting. So how is it possible, I've given you some case reports on some remarkable conditions. How is it possible doing nothing can be more effective than doing anything when it comes to some of the leading causes of death and disability? Let's look at possible mechanisms. What percentage of people that fast lose weight? Doesn't that sound quacky? 100% effective. But the laws of physics and thermodynamics tell you if you don't eat, you lose weight. You know, we know average weight loss is a pound a day. Natriuresis, the selective elimination of the excess sodium from the body, happens selectively in fasting. It's much more powerful than, say, diuretics or the things we commonly use. Powerful natriuretic, now that's important because you get rid of the excess fluid by getting rid of the excess salt that follows it, and that means your blood volume goes down, blood pressure comes down, the non-healing wounds heal, the congestive heart failure starts to ease, the respiratory congestion starts to back off. It's a very powerful effect and allows us to rapidly reverse many of these conditions of congestion. Detoxification, are people really toxic? Is that true? Do people really have toxins in their body? Is toxemia real? Is there PCBs, dioxin, pesticide residues, heavy metal contaminants inside your cells that can accumulate and interfere with cellular function? We know that's true because you can take a fat biopsy and break it down, and you'll find hundreds of different chemicals in various concentrations in different people's tissues. Or you can do with cadaver tissue, you can analyze that. Now, different levels of toxicity in different people. Where does 90 to 95% of the total body load of toxins in the average person come from? Is it drinking water, breathing the air, eating vegetable foods? No, it's the consumption of animal foods. Meat, fish, fowl, eggs, and dairy products biologically accumulate materials in the environment. When you eat a calorie of animal foods, you can get anywhere from 2 to 1,000 times the concentration. People are toxic to varying degrees. Some people are more sensitive to one thing or another. You don't know what your thresholds are, which is why a good idea is to avoid exposure to toxicity, which means adopt a completely vegan diet that's free of added sugar, oil, salt, and avoid the environmental chemicals as best you can. Autophagy, which is the ability, we've heard about that this week, and the ability of the body to eat up cancer cells and get rid of cellular debris is enhanced during fasting. Multipotential hemopoietic stem cells. You hear about stem cells become the other cells. Stem cells are sensitive, for example, to radiation, which is why medical treatment to treat cancer kind of gets screwed. Because if you want to kill each and every cancer cell, and you give enough radiation or enough chemotherapy to kill all the cancer cells, you usually kill the host too. And if you don't kill all those cancer cells, they tend to come back. That's where Walter Longo did some interesting research. He took 30 rats with cancer and gave them enough chemotherapy to kill all the cancer cells, all the rats died. Take the same rats with the same cancer, but fast them, all 30 rats survive, dramatically enhancing cancer-free survival. So we talked about differential stress sensitization and differential stress sensitivity. It turns out that healthy cells are protected during fasting against the ravages of chemotherapy. And cancer cells are actually more vulnerable to chemotherapy, probably because of their higher metabolic rate. Now they're starting to use this tool in the treatment, not just of rats with cancer, but also with humans. And that's why a lot of drug companies have become interested in fasting, because what they're hoping to do is figure out how does fasting work to generate these results we talked about so they can come up with fasting mimic drugs. So a drug you take that would do to you just what fasting does, but without that nasty fasting, and in a form that they can sell. According to Walter Longo, published in the Journal of Metabolism in 2013, big hit journal that says combination of fasting and chemotherapy results in dramatically higher cancer-free survival than chemotherapy alone. And it turns out that the mitochondria of the cells themselves are affected by fasting. And so you can rejuvenate these mitochondria, the energy-producing components of the cells, in the fasting state, and it also enhances antiviral immunity. So viruses, don't respond to antibiotic treatment. So, but you can treat some of these chronic viral infections during the fasting state, but the body will actually fight off the problem itself. Walter Longo, also, I'll just skip down here where it says in humans, we know that fasting reduces obesity, asthma, arthritis, and treating high blood pressure. He actually cited our data in his most recent article. And so I evaluate another researcher's intelligence based on how much they did us. So he's getting close to being a genius. He also wrote in his book, don't do long-term water-only fasting unless you do it at the True Health Center. Yeah. Enzymes are used to detoxify your body. How do you think the toxins get out of your body? There's various enzymatic systems involved. It's the same types of things that are used to mobilize nutrient reserves, like lipolysis or gluconeogenesis, breaking down fat, breaking down protein. When you go on a fast, you induce these nutrient mobilizing systems, and you induce these detoxifying enzyme pathways. And they persist. So you're not just better during fasting at detoxifying, you continue to be better as a consequence of it. And that's why even one night of 12 hours or 14 hours of fasting induces a little bit. What I think we're going to find in the studies that we're doing is that long-term water-only fasting has geometrically bigger impacts than even the shorter intermittent fasting benefits that they've been making such a big deal about in the literature. Proof will come soon because we've completed the first study of long-term fasting along with Luigi Fontana at Washington University and the Buck Institute, where those samples were taken before, during, and after long-term water-only fasting, and those results will be coming in, hopefully, in the next few weeks, and so we'll be able to know once and for all, at least whether or not these theories that we have that long-term fasting is inducing these changes actually is in fact true. We already learned about brain-derived neurotrophic factor, and these other factors associated with improving health, reducing debility, go up with exercise, go up with fasting. As I mentioned yesterday, it's probably because both exercise and fasting are undoing the consequence of dietary excess. Insulin is a hormone that drives sugar from your bloodstream into your cells. If it doesn't work, you call it diabetes. That's essentially what diabetes is the inability to drive the sugar into the cells where it's needed. Well, exercise helps reduce insulin resistance, and so does water fasting. In fact, profoundly so, as much as 80% of our type 2 diabetics will achieve normal blood sugars without the use of medication. The gut is a tunnel through your body. If you swallow something, is it in your body? No. It's going through your body. It's not in your body unless it's absorbed through the intestinal mucosa represented here by a screen that works very much like a screen works to keep flies out. The holes are small enough, the fly can't get through. What if the screen becomes damaged? The flies would get through. What could damage your intestinal mucosa? What could cause your gut to leak? How about the free radicals we learned about from Dr. Sabatino? The reactive oxygen molecules that you can get from doing things like, I don't know, smoking. And then you get to have smoker's face, right? What's a wrinkle? A cross-linked collagen tissue. That's all it is. And when you smoke, you bathe your body with cross-linked collagen tissue, or cross-linked tissues, causing the collagen to wrinkle, to prematurely age. And you get smoker's face. Do you think smoking just affects the face, or does it affect the inside of your blood vessels? Sure. Why do you think 80% of smokers never get lung cancer? because they die from heart disease. Fasting normalizes the autonomic nervous system, which is, there's a sympathetic and parasympathetic nervous system. They work in balance with each other. So if the sympathetic system gets too high, you may have symptoms like constipation. Or if you have symptoms like diarrhea, it might be because the parasympathetic system is too high. We have hundreds of systems of healing that are designed to balance the system, like massage, biofeedback, chiropractic manipulation, physical therapy, homeopathy, acupuncture, all these things we do to try to feel better that work to varying degrees. The most powerful way of rebalancing the autonomic nervous system that works like taking a computer that's corrupted and rebooting the hard drive is fasting. Fasting, it's interesting, all the religions that are diametrically opposed to each other, right? The Jews, the Jains, the Hindus, the Christians, everybody that wants to fight over so much stuff, they all agree on one thing. Every one of them has a tradition about fasting. The immune system is enhanced during fasting, it's not suppressed. Every objective measure of immune function tends to be enhanced: helper killer, T cell activity, lymphocyte phagocytosis. And perhaps most importantly, or most conveniently I should say, is taste meditation. The taste change in fasting. People go from not being able to eat healthy foods because they're addicts to being able to like foods, and that's best explained in a quick story about our remember I told you the union signed a contract for this? The first guy they sent us, very first guy, hypertensive diabetic, 240 over 120, capped out on medications, big keg on his belly, comes in, but they don't tell him what the program is. So he shows up at our place. He has no idea. He thinks he's coming for a sixth drug, right? And I say, oh, welcome. He says, yeah, I'm in the wrong place. I said, you're not in the wrong place. I got your name right here on the list. He goes, no, I'm in the wrong place. I said, no, you're here to get well. He says, no, I'm not sick. I said, what do you mean you're not sick? So your blood pressure is out of control. You got diabetes. You got this big keg on your belly. I said, you're going to die. Because I thought that'll. And he said, oh yeah. He says, well, aren't we all going to die? Good point. Different tact. I said, look, you're on $860 a month of medications. If we get you off all these drugs, you won't need all the drugs. He says, what do I care? The union pays for my drug. So at this point I realized, this is not my normal natural hygiene, self-motivated. I'm not sure, what am I going to do with it? I'm thinking about his medical history, going, what happens to men that are on a lot of diabetic and hypertensive medication? So I said, well, if we get you off all those drugs, we might be able to do something about your little problem. He starts to stand up, and I'm thinking, uh-oh. Because he's a pretty big guy. And he says, well, why the hell didn't you just say so? So we're getting ready to try to check him in, and we thought, well, he's telling me about his diet. This is his diet. I couldn't get a picture of exactly his diet. It's this, but without any of that disgusting green stuff. If they put that on his triple cheeseburger, he'd take that off and chuck it away. So, I think, okay, let's feed him a little bit of real food before we start fasting, because, we don't want to have to manually disinfect this from him. So, we give him some food, and he's like, and I'm thinking, what, did we miss a tumor or something? It looks like you're having some trouble eating the food. And he says, what food? He said, this is not food. He said, this is disgusting. And if I have to eat tasteless swill like this the rest of my life, I'd rather just die. He says, why don't you go out to my truck and get my 12 gauge, and when I'm not looking, just shoot me in the head. So we checked him in. He fasted 26 days. Lost about 50 pounds, normalized his blood pressure and diabetes. Got him off his meds. When we're done with the fasting, we're starting to feed him again. Only now he's actually eating the food. And I sat down with him, I said, oh, it looks like you're doing a little better with the food now. He says, yeah, your damn chef's finally getting the hang of it. I said, it's the same food. He said, God, that stuff you tried to make me eat when I came in was disgusting. He said, but this is not bad. He wouldn't have complied for a meal pre-fasting, but after fasting now, that's taste and orientation. So, in summary and conclusion, fasting decreases glucose, IGF-1, blood pressure, heart rate, insulin, inflammation, oxidation, and total microbial load. Helps rebuild that 5 pounds of bacteria living in your gut. And think about that like you learned from Dr. Furman. If you feed that bacteria meat, you get TMA. which becomes TMAO, which is trimethylamine oxidase, which is highly irritating, causes heart disease and cancer. You feed that bacteria soluble fibers, and you get vitamin K and fertilizer. So you want those organisms pooling into you good stuff, not toxic waste. Fasting increases leptin, the satiety hormone, insulin sensitivity. It improves cellular stress adaptation and resistance. That's the part where cancer cells don't like the fasting state, and healthy cells are protected. It increases autophagy. It normalizes the gut microbiome. It stimulates B-cell immunity. It reverses all major abnormalities of metabolic syndrome. And if you'd like to learn more about fasting, come out and get the last of the Pleasure Trap books. Thank you for your attention.
So, Alan, what do you think that guy would have thought of the food that we had here?
Not bad.
Not bad.